Hello, hello, and welcome, welcome, welcome. I am Vic Jagger, morning show host with Magic 102.3 and 92.7. I'm so happy to be here. Welcome to our panel, The Impact of Breast Cancer on the Black Community with the Johns Hopkins Kimmel Center. Now, this is a special live stream event. We're going to have a lot of information for you all. And as you know, information is power. And DC has one of the highest rates of breast cancer in the country, and African American women are hardest hit. So we had to get a panel of experts in today, and I'm going to just introduce everyone. Welcome our panel of experts. Senkuta Riverson, hello and welcome.
Thank you.
Dr. Ashwani Rajput, Dr. Pouneh Razavi,
Hi.
Dr. Jean Wright,
Hi.
Dr. Cesar Santa Maria,
Hi.
and Meagan Paulk. Welcome, and I am ready to get things started. Dr. Rajput, take it away.
Well, thanks so much, Vic. It's great to be here with you and my colleagues from the Kimmel Cancer Center and also our colleagues from the DC Department of Health. And it's such an important topic for us to be discussing because 1 in 8 women in the United States is going to be diagnosed with breast cancer. So I think everybody here knows someone that's either in their family or a close friend that's been diagnosed with breast cancer. And we've made a lot of progress over the years. And when we look at all types of cancers, the mortality or the death rate from cancer peaked in the 1990s. And we've actually decreased that mortality across the board almost 30%. But, when we look at specific subsets of the population, not everyone has benefited equally, as you talked about in your introduction. And so across the United States, when you look at breast cancer mortality, it's really decreased. And for Black women in the United States, it's also decreased. But mortality from breast cancer for Black women in DC is about twice as high as that it is for white women, and about 20% higher than it is for Black women across the United States as a whole. So we're really excited to partner with you in Radio 1 and the Department of Health to really increase the importance of early diagnosis and treatment, because the truth is that 90% of breast cancers can be cured if caught early and appropriately treated. So thank you for making this such an important event tonight.
Yes, thank you. I just want to learn more info so that I can spread the word as well. And I know that our listeners and our viewers want that information too. So we're going to get started with Dr. Santa Maria. So I have a 2-part question for you. How common is breast cancer compared to other cancers? And can you explain why Black women are at a greater risk than other women for developing this disease?
Yeah, no, thank you for the question, Vic. So breast cancer is very common. Unfortunately, like Dr. Rajput mentioned, the lifetime risk of breast cancer for a woman in the United States is 1 in 8. Like Dr. Rajput mentioned, it's very common and, something that you may come in contact with through a friend or a family member. And it is a risk that increases with age, but young women can get breast cancer as well. There's different reasons to develop breast cancer. Some of those are genetic. One of the most common genetic mutations that can lead to breast cancer is what's called mutations in the BRCA gene. So this is a hereditary gene that can be passed along. And mutations in BRCA are more common in African American women. So that accounts for some of the disparities. And also there's different types of breast cancers. We think about breast cancers according to different receptors that may be on the breast cancer cells, like the estrogen receptor or the HER2 receptors. And when breast cancers don't express any of these classical receptors, we call them triple negative breast cancers. This subtype of breast cancer is a more aggressive subtype of breast cancer. And also, this is a breast cancer that's associated with patients who harbor BRCA mutations, but also this is a cancer that's associated in women who are African American. So these are some of the unique features that we might see in patients who are African American.
Dr. Wright, I'm going to throw it to you. Can you talk about the key factors for breast cancer and how you can reduce your risk?
Sure. So I think that Dr. Santamaria did an excellent job covering a lot of the sort of genetic risk factors and what we'd sort of put into the category of non-modifiable risk factors, your age, your race, your family history, things like that. There are a few categories that we would consider modifiable that are things that patients could address, such as diet and exercise and alcohol use. We know that a lower alcohol intake is associated with a lower risk of developing breast cancer, and having a lower body mass index for postmenopausal women is also associated with a lower risk for developing breast cancer. So there are a few sort of modifiable things that people can do, but I would say that even those are generally associations. So if a patient has a higher body mass index, we can't say that that's specifically what caused the breast cancer, but just that at sort of a societal level, we see these associations. So I think it's really important for people to recognize that it's not something that that you can actively prevent. You can make healthy lifestyle choices, but people who make healthy lifestyle choices still can develop breast cancer. One thing that I find is a lot of patients will say, I had a healthy diet. Why did this happen to me? Or will try to assign blame in some way because they, made an unhealthy lifestyle choice. And I think it's really important to recognize that, the majority of breast cancers are what we call sporadic or random, meaning that we don't really have a specific cause for them. And really, this brings us to the topic of screening and early detection being the best, method that we have to address this issue.
Dr. Rajput, can you go into further detail? You were talking about some of the reasons for the disparity. Can you go into further detail about that?
Sure. One of the differences in the disparity of the outcome or the mortality rate, I think, has to do with stage of disease at the time of diagnosis. And when we talk about cancers, we usually have 4 stages of disease, with stage 1 being the earliest, and then stage 4 being later, or if the disease has spread in the body or if you have metastatic disease. So when we talk about, being able to cure someone, the 90% of patients with breast cancer that we cure are more of the early stage disease, although some later stage disease we have success with too. But that's the importance in early diagnosis. And what we're finding with some of the patients that we're seeing in DC is that some of the Black women present at higher stages of disease, meaning stage 3 or stage 4, which makes it more difficult to treat or increases the risk of mortality. So that's one, the importance of early diagnosis would be very important.
Senkuta, is there anything that you can add for the Department of Health's perspective?
Sure. So DC Health recognizes the burden of breast cancer is not equally shared among district populations. Just like Dr. Ash mentioned, our most vulnerable populations, including Black women, remain at high risk of developing and dying from breast cancer. We are committed to reducing this disparity by partnering with health systems, hospitals, clinics in the community to implement initiatives that increase screening and promote prevention. So our main priority is working to get people to appropriate screening, timely screening, just like Dr. Ash mentioned, making sure people are diagnosed early so their prognosis and outcome is the best, and helping them complete their screening and follow-up testing by ensuring they have access to the screening, whether they're insured or not insured, and addressing barriers and challenges they may face through patient navigation.
Good info. Now, Meagan, how is this being addressed specifically at Sibley?
Sure, thanks. So at Sibley, we actually partnered with Unity Healthcare, which is a major provider of primary care services throughout the district, to provide navigation services to patients. So anybody that's seen at Unity that has a suspicious finding of cancer or a confirmed cancer diagnosis can work with our program, and we navigate those patients up to Sibley for additional testing or to go directly into oncology services depending on what they need. The biggest thing that sort of sets this apart is that these navigators are dedicated to patients directly coming from this referral source, and we address barriers to accessing care, like Senkuta mentioned. So things like insurance, even if they don't have insurance, we will still work with them and make sure that they're covered. And the biggest access, what we tend to find, and I think is true at most cancer centers, is transportation. You know, even though a lot of our, people that might have Medicaid or free health insurance have transportation benefits often through that, it's not always reliable or difficult, for them to arrange. So these patients tend to need a lot more hand-holding, and our team is able to do that for them. And it's actually been a great partnership, and it's been helpful to make sure patients get access to the care that they need.
Awesome. So I want to switch over to screening with Dr. Razavi. Now, I will say, when I turned 40, I just heard all of the stories, and I was like, wait, I have to go get a mammogram. It's that time already. And what can I expect? And I'm asking a lot of women, and I got different, descriptions and different experiences. And some were, I'm not going to lie, some of them were horror stories, but some of them you really said it's okay. They're going to take good care of you. This is what's going to happen. So can you talk about first how breast cancer is detected?
Sure. So usually breast cancer is found one of two ways. Either the patient or their doctor feels something abnormal on the patient's breast exam, or they notice a change on themselves, like a nipple discharge or a palpable mass, or the breast cancer can be detected by screening methods. So as Dr. Rajput already alluded to it, the most important thing that we can do for patients is to find the cancer early, so that at the earlier stage, we know the patient has a better prognosis, less mortality and morbidity associated with the disease. This is where screening comes in and is so important, because the goal of a screening mammogram, and it has been shown to be successful for mammography, is that we find breast cancers early, long before a patient feels it or sees a change, and long before the doctor feels it. That's our goal, is to find it early. So it's a stage 1 or very early breast cancer that has not involved the lymph nodes and has not gone elsewhere. Those cancers are easier to treat. So when it comes to your question as the mammogram, I think being informed about what you're going to expect is the most important thing for patients to know. Yes, there are many horror stories about mammography, but I think, it's a small thing to do for yourself and for your loved ones to make sure that you're healthy for them. So we always tell patients, if you feel like it's going to be uncomfortable for you, take some Advil beforehand. We do encourage patients to come with a friend. Sometimes that works out really well for them, or come with a family member, a sister or mother, come together or schedule your appointments together. Patients, what they need to understand is that it is uncomfortable for a few seconds when each image is done. And usually we do 2 images of each breast. And that gives us a wealth of information about the breast as itself, as the tissue, and make sure that there's nothing there. For recommendations, we recommend that a patient start at 40, as you said, because actually 1 in 6 new cancers are for patients in their 40s, and have it done once a year.
Now, I do have a question. This is my own personal question. I've spoken with quite a few women who went to their first screening, and they were explaining lumpy breasts and how they had to go back. And I was like, well, is that normal, for you have to go back and to get it done again? Can you just speak to that and kind of explain what that is?
Sure. Usually when patients speak of lumpy breasts, it's what we call dense breast tissue on a mammogram, which means that all breast tissue is composed of glandular tissue and fatty tissue. When there's more glandular tissue and less fat, the breast tissue on the mammogram and sometimes on the clinical breast exam feels lumpy. On a mammogram, it's a little bit harder to read the mammogram when there's more glandular tissue, because fatty tissue is easier for the X-ray beams to go through and get us a nice picture. So you're correct. Oftentimes for the first mammogram, we do call a patient back, because we're trying to figure out what is the patient's normal breast tissue pattern versus if it's something that we need to be concerned about. So the first mammogram can be the most challenging because we're trying to tease out what is the normal mammogram pattern for that patient. But usually moving forward, it's not, it gets easier because then we're looking for changes. And that's why it's so important to have your mammogram done at the same place or take your old films with them. I do think it's important for patients to know that we do call back about 10% of patients, but out of those 10%, 90% is not anything to worry about. And those patients will have a normal mammogram at the final outcome.
And after the screening, can you talk about what women could expect when she talks to her doctor about the results?
Yes. So if the screening is completely normal, you get a letter in the mail and your report goes out into whatever portal system. If it's done at Sibley, we have MyChart, Johns Hopkins, that the patients have access to. If the screening is abnormal, for example, I can only speak about how things are done in the Johns Hopkins system. We actually have a coordinator who calls the patient and helps facilitate scheduling the patient to come back for their imaging. And as I said, 90% of those follow-up images, which might include a couple of images, perhaps an ultrasound, usually are benign, and the patient can resume their annual screening mammogram. In the 10% of those 90, if they need any additional workup, like for example, an image-guided needle biopsy, we also have a coordinator that helps schedule that before the patient leaves so that the patient doesn't feel abandoned and doesn't feel that I don't know what to do next. We really figuratively walk through it, and sometimes literally handhold the patient through each step.
And that makes a big, big difference, let me tell you. Senkuta, I want to throw it to you. For women who live in DC, are there any low or no cost resources to have their breast cancer screening completed?
Yes, there are low and no cost resources. DC Health's Breast and Cervical Cancer Early Detection Program, which is known as Project WISH, and WISH stands for Women into Staying Healthy, provides free breast and cervical cancer screening and diagnostic services for women who don't have insurance or who may not be able to cover their copay or deductible. In addition to giving this screening, Project WISH also provides patient navigation, what Meagan essentially described about like walking that woman through the whole process and ensuring if she has transportation needs or needs assistance going through Medicaid or any other assistance that is provided. Also, we do cancer education within the community, working in the community to bring women awareness and bring them into screening is also part of what we do. We currently work with Howard University, Breast Care for Washington, Family Medical Counseling Services, Capital Breast Care Center, which is now Ralph Lauren Center. They all provide this no cost to low cost breast cancer screening service. If you want additional information on Project WISH, you can find it on don'tdelay.today, that website, as well as you can email us on project.wish@dc.gov or call 202-442-5900. And all that information is on the don'tdelay.today website.
And we have that website scrolling at the bottom of the screen as well. I want to throw this question to Dr. Santa Maria and then Dr. Wright. So can you speak to the process of a breast cancer diagnosis, what one woman might experience when she receives that diagnosis?
Yeah, absolutely. So when we think about breast cancer diagnosis, there's really two important parts to the diagnosis. The first is the type of breast cancer. Like I mentioned earlier, there's some receptors that after a biopsy takes place and a breast cancer is confirmed, there's certain receptors we'll look for in the breast cancer cells. There's two hormone receptors, the estrogen and progesterone receptor, and another called HER2. It's really important to define these receptors because this is how you're going to know what type of breast cancer you have. Do you have a hormone receptor positive breast cancer, which would be the most common type of breast cancer? Do you have HER2 positivity, which opens certain treatment options against HER2? or are there none of those receptors? You have what's called the triple negative subtype of breast cancer. So knowing the type of breast cancer is really important. It helps define what kind of treatment options we'll think about. The other really important part of the diagnosis is stage. So stage really is a description of where the breast cancer is at. So we consider stages 1, 2, and 3 to be early stage breast cancer. The goal of treatment with early stage breast cancer is cure. So trying to get rid of the disease and doing everything we can so it doesn't come back. When one is diagnosed with stage 4 breast cancer, that means that it's in other parts of the body. The disease is not curable, but certainly it's treatable with many medicines we now have, and our goals of therapy are a little different, obviously, in that setting. But knowing the type of breast cancer and the stage of your breast cancer is essentially what gives you the diagnosis. And then irrespective of what type of breast cancer, what stage of breast cancer you have, then what you can expect is to work with a medical team, and it's going to be comprised of several different types of doctors. There's so as a medical oncologist, what I focus on is giving different types of systemic therapy, so like IV or oral medications that fight cancer. Particularly for early stage breast cancer, we'll work with surgeons as well to help think about when's the right time to remove the breast cancer. Sometimes we'll do treatments before surgery, sometimes we'll do some treatments after surgery. And then we work very closely as well with radiation oncology, both in early stage and metastatic settings. And I'll pass it over to Dr. Wright.
Sure. So I'll just pick up the thread talking about just this sort of wide array of different treatment approaches that would be appropriate based on the patient's presentation, the subtype of breast cancer they have, the stage of breast cancer that they have. So I think that today we really view breast cancer as, kind of a spectrum of diseases. It's not just one process. And there's so much individualization of the treatment. Whether a patient needs, one or some combination of the different treatment approaches that Dr. Santamaria mentioned, from systemic therapy to surgery to radiation, and also the sequencing of those, and then just, the specific type of treatment. Just with my focus as a radiation oncologist, I'll comment on radiation therapy specifically. So many patients, not all, will receive radiation therapy. Typically, this is something that's done after surgery. And in the past, what many people, or people who have gone through it or have family members who have gone through this type of treatment, will remember very long courses of radiation therapy where patients have to come every day for 5, 6, 7 weeks. There are still situations where patients need to have these sort of prolonged treatment courses. But more and more, we're able to offer shortened treatment courses that might be between 3 and 4 weeks, or in some cases down to only 1 week of treatment, depending on the clinical situation. And there are a lot of studies that are going on right now looking at even patients who may have such a low risk of recurrence that we can avoid radiation therapy altogether. So again, the patient experience of what the optimal treatment for their situation is going to be, very specifically tailored to their diagnosis and their situation. But I think that's a very fortunate thing in that patients are now getting more appropriate treatment. Sometimes that's less. Sometimes that could be even an intensified strategy. Dr. Santamaria, there's a lot of different systemic options that can be considered, but it's really, very patient specific.
So I had a question for Dr. Santamaria or Dr. Wright. When we talk about the future of cancer treatments and things like that, are there any promising new medications or treatments that you guys are keeping an eye on or just watching out for right now?
Yeah, no, absolutely. I'm happy to take this on initially. So there's lots in the pipeline. As over the decades, we've really learned a lot more about cancer biology, about what makes cancers tick and grow, and how we can target them in new ways to kill cancers. And this has really led to many new treatments that have been developed that have really changed outcomes. And cancers that were previously, frankly, quite lethal have now become some of the most curable subtypes of breast cancer. This is something I truly believe in, and I talk to my patients about. I think really clinical trials are a part of modern oncology care. So this is how we've developed all these new standard drugs that we use in clinic. And we're still building on that, and we're still continuing to try and optimize and improve our treatments. Sometimes it's developing new treatments, sometimes it's learning who needs what. At an academic center like Hopkins, that's an important part of what we do. And Sibley in particular, the hospital we're representing right now, has a really terrific clinical trial portfolio that's available to patients. So, I think if you've been diagnosed with cancer, that's something you might want to talk to your doctor about. Are there any new treatments? Are there any clinical trials that might be right for me? And just asking that question can start a really important conversation.
So we have a question from Dina Lancy on YouTube. Her question is, can the doctors explain what the stages of breast cancer mean? We would like to take that.
I can go ahead. I think it was related to some of what I covered earlier. So stage is really a description of where the breast cancer is at anatomically. So we think about early stage breast cancers, we divide those up into stages 1, 2, and 3. Stage 1 breast cancers are usually small, just confined to the breast. Stage 2 and 3 breast cancers are usually larger, and they may involve some of the local lymph nodes nearby. Stage 1, 2, and 3, so localized breast cancers are treatment goals are cure. Stage 4 means it's in other parts of the body, like common places would be like the bones, liver, lungs, and in those situations, it's not a curable paradigm. We're not able to get rid of the disease forever, but we certainly have lots of treatment options and lots of options being developed as well.
Did you mention triple negative? You did.
Absolutely. So that's a subtype of breast cancer. So diagnosis has to do with the type of breast cancer and the stage of the breast cancer. So those two things kind of get you your diagnosis. And triple negative is one subtype of breast cancer.
Okay. Dr. Rajput, we hear a lot about, mastectomies and women who say I had to get a double mastectomy. Can you speak about the various breast surgeries, why they're necessary, and then life after that?
Sure, that's an excellent question. And the field of surgery has evolved also. And in fact, breast cancer surgery was developed at the Johns Hopkins Hospital in Baltimore with what we call the Halstedian mastectomy. So for our listeners who might have an older member in the family or a friend, in the old days, we used to do what we called a radical mastectomy, and that involved taking off the breast tissue as well as the chest wall muscle, and then all the lymph nodes in the armpit or the axilla. And you can imagine that that was quite a disfiguring operation. And because of wonderful clinical trials and innovation, we've gotten to a point where we can talk about breast conservation surgery. And so we no longer do these radical operations and removing the muscle unless it's involved, but we can minimize the operation with the same outcome. And when I say minimize, we talk about lumpectomy. So we can really tailor the treatment based on what the patient's needs and desires are. So with the combination of the surgery, radiation therapy, and potential medical oncology, we can conserve the breast tissue. For those women who do have to have a mastectomy, or because of high risk conditions such as a BRCA mutation, where they want to get a prophylactic mastectomy done, we have options also for reconstruction with our plastic surgery colleagues. So we want to, number one, of course, talk about cure and prevention, but also then talk about the body image as well.
Great. Meagan and Senkuta, question for you guys. So let's talk about, how patient navigators at Project Wish and also at Sibley Memorial Hospital help women through their screening, through their diagnosis, and through their breast cancer treatment.
Sure.
Go ahead.
So I was going to say, sometimes it's overwhelming for a patient to go through the healthcare system. It's complicated, and at times the journey through screening and diagnostic testing could be scary. And navigators are really there to help patients through that process. Patients can experience several barriers, like we've talked about, transportation, et cetera, but it also includes fear and misconceptions that they have to overcome. And navigator is like that friend that walks them through that process. They connect them also to safety net and community resources. If the patient is diagnosed, they also do a warm handoff to the cancer center to initiate treatment. So it has like nationally, we've seen navigation has worked successfully in patients throughout the continuum of screening, including diagnostic testing. And it's really something at DC Health we are trying to bolster and make sure is available to patients.
Yeah, that was beautifully said. They're kind of that person, your go-to person, especially if you end up, unfortunately, with a cancer diagnosis, because any chronic illness can be really overwhelming for anybody, and especially entering the world of oncology. It's like learning a new language. It's on top of being really overwhelmed. Fear and anxiety are the most commonly reported impact for someone's mental health when they get a cancer diagnosis, and just having to go through everything. So having that point person is really important. At Sibley, the navigators that I mentioned through our partnership with Unity, and also we have other navigators based just through our cancer center, act as that person for our patients. And then they also link to other resources within Sibley and in the community if it's something that we don't have on site. But we can connect with our social workers who provide ongoing counseling and psychosocial support. We have support groups, ongoing survivorship programs that are constantly evolving to meet the needs of our community. And as well as we have dietitians and other specialty services, palliative care, just to mention a few. But usually it's the navigator and sometimes the social worker, whoever the patient kind of links up with. It tends to be the navigator that is that person that helps to direct you and your go-to whenever you have a concern, and can get you to the right people.
I'll just say a few words also. For the patient going through treatment, we talked about that, they may be experiencing surgery, radiation therapy, different forms of systemic therapy, and these all have to be really carefully coordinated. So having somebody that can sort of help navigate the patient from one discipline to the next, because you may be primarily under the care of one of the physicians for a portion of the treatment. But ultimately it's a very complex kind of multidisciplinary process. And I also wanted to highlight what Meagan was talking about with nutrition services. We do have genetics counselors to help patients identify if they are at an elevated genetic risk, and are they a BRCA mutation carrier, et cetera. And another thing that a lot of patients worry about, and that we do, I think, a very good job of managing with modern breast cancer therapy, is kind of the body effects, the musculoskeletal effects. So we make referrals very frequently to physical and occupational therapy, particularly for patients who require lymph node surgery or potentially lymph node radiation. So the multidisciplinary team, goes kind of well beyond the physicians and even navigators, and there are a lot of different individuals that are, providing supportive care through this very complicated journey.
Meagan, I'm going to throw it back to you. What can family and friends do to help the women in their lives to stay healthy?
Might be better for one of the docs, but generally, helping to make healthy choices, which I think some of the docs here have already mentioned, but also I think generally what we're doing here, so spreading information, encouraging your family members to go get screened when they're ready, seek medical care, you know, and keep going until you find trusted providers and people that you know, can help direct you when you have concerns. Because I think some, you know, and I think Senkuta had mentioned this, sometimes it's overcoming misconceptions from people about where they can seek care and that they can access it. And sometimes that can be its own barrier. So that can be helpful for people. But I think like specific healthy choices, I would lean on some of the docs here on this call, maybe could chime in.
Yeah.
Well, I'm going to say also, piggybacking on what you just said, Meagan, I think it's so important for family members to make sure their loved ones start screening for breast cancer at the appropriate age and continue it annually. We know that breast cancer screening saves lives. And that's just a fact. And there are horror stories, as we talked about mammography, but really it's a small amount of time to take for yourself to make sure that you're healthy for your loved ones.
Yeah. And Dr. Razavi, I'm sorry. Can you speak to some of those the women who are nervous, some of those misconceptions? Because like I said, I heard horror stories, but my experience was amazing. You know, it was seamless. Mine was painless, despite some of the things. It wasn't as uncomfortable as I thought. But can you speak to some of those misconceptions that women like myself might have heard, and why it is just important to just, you know, get it done and make sure that you stay on top of it every year?
You know, and that's such a good question. I think one of the things is that the mammogram units are actually better. I mean, we still do have to compress the breast tissue between two plates and take an x-ray. So that's not going to change, not yet anyways. But the technology is better. You know, we have 3D mammography. The images are taken much more quickly. They come up quickly. So the technologists can assess the quality of the imaging right away, just like a digital picture, just like when you take it on your phone, how quickly it comes up. It's the same thing. Same concept. So it's very quick, and it's a much faster way for the technologists to assess what they've taken and if they need to take any more pictures. You know, it used to be that the technologists would have to run the films and check the quality while the patient waited. I mean, that was a lot of time for one patient to get a mammogram, but that's all we had at that point. But now with all the new technology and you know, we are proud to say that we have that available for all of our patients at the Johns Hopkins sites and Sibley. It makes it relatively easier, I say, for the patients. I mean, you still have to get, you know, compression for the breast tissue. That's not something we can change right now, but it is relatively easier than it was from before. And I think some of those horror stories are just basically passed down from generations, right? So, but I'm glad to hear that you've had a different experience, and I'm glad to hear that you're sharing it with everyone. It is really important for everyone to be truthful and honest about their experience and get the information out.
Yeah, my friends and I, we all turned 40 around the same time. So everyone was sharing their experience. I do know someone who was diagnosed with triple negative breast cancer, and I didn't know much about it. So I had to, you know, do a little research, and I thought it was, at first, I thought it was something that was just like, oh, you know, maybe it's not as serious, you know, it's triple negative when you hear something like that. But that's why it's important to really do your research, to talk to experts like yourselves, and to really get the information. So we have a question from Jennifer Dean on YouTube. She says, I often find myself advocating for thrivers to ask about clinical trials because it doesn't seem that clinical trial information is readily available or offered to them without them asking. Is there a reason for this? Does one have to request the information when speaking to their oncologist? Anyone like to take that?
I'm happy to take that one. That's a great question, and thank you so much for asking that, Jennifer. You know, It's hard to navigate, is the truth of the matter. There is a central repository of all clinical trials in the US called clinicaltrials.gov. But it is very difficult to navigate, and I think another misconception of clinical trials is, that's something you kind of go to when you have no more options. And you're just, looking for new treatment options. And that's really not true. We have clinical trials both in early stage and in for metastatic breast cancer, and they can serve different purposes. Again, not just escalating therapies or looking for new treatments, but optimizing therapies as well. For example, we have a study right now to see, do all young women who have lower risk breast cancers according to their genetics necessarily need chemotherapy, so there's uncertainty. So we're doing a clinical trial to better understand that. The best place to start, I do think, is with your oncologist and just asking them, is there a clinical trial that might be a good option for me? Many community sites will have, clinical trials. So, however, I think most of the clinical trials are going to be run out of academic centers or larger cancer centers that have more clinical trial infrastructure, like we do at Sibley and Johns Hopkins. So, I personally work with a lot of community physicians who will occasionally refer patients who are looking for clinical trials, but I think kind of a good entry point is and just talking to your oncologist. There's more information you can get online through certain websites. The Johns Hopkins website has our clinical trials as well. But sometimes navigating just through the internet can be very challenging. So I do think that it's something that good communication with your oncologist regarding that is key.
So I have a question for Dr. Razavi, or anyone can really answer this question. What can women do before they are of recommended screening age to stay healthy, healthy lifestyles, healthy eating? Can you speak to that?
Well, I think one of the things that we alluded to earlier is that there are some risk factors that may be deemed a little bit modifiable. For example, alcohol intake should be moderate. We talked about the BMI, and try to keep healthy with that. But I think when it comes to screening, if you're asking what can patients look for before they're ready to be screened before they hit 40, for the average population, I do think it's important for patients to know their own clinical exam. They should know their own breasts. They should know they're familiar enough with it that if there is a change and there's a lump, that they should actually be able to recognize it for themselves first. We often have younger patients who are not at the, actually I shouldn't say we should often, most of our patients who are younger and not at the screening age have breast cancers themselves because they note a change either on their self-breast exam, or they note a symptom like nipple discharge, for example, or skin changes. So I think it's very important for patients to be aware of their own bodies and to be advocates for themselves. So if one sees a change, that to seek their medical provider, their primary care provider, and be aggressive, be an advocate for yourself, and make sure that your doctor follows up with the appropriate imaging. Example, if you are over 30, you would definitely need to start with a mammogram and an ultrasound. If you're under 30, you might just start with an ultrasound. But it's very important for patients to be referred to us, and that really does begin with the patient recognizing the change themselves. Does anyone else from the panel have anything they want to add in?
No, I was just going to sort of, reiterate this idea that I think making healthy lifestyle choices is important for so many reasons, to do with your mental and your physical health, not just preventing breast cancer, but, just overall health. But I think that, there really isn't a particular diet that we know is, associated with a lower risk. And, people talk about all kinds of diets that they've read about, or that they've heard about, or that they or someone in their family follows. And I always encourage people to just find something that, is a diet that works for them, an exercise habit that works for them. That's not going to be the same for everyone, but it's more important to just, kind of adhere to a general sort of healthy lifestyle principles than to, be really rigid in a particular way. So I think that, again, that's just something that people can sort of take the pressure off themselves a little bit and just focus on on a lifestyle that works for them.
And so this question is for the entire panel. Is there any information, any resources that we have not covered that you would like to share with our audience this evening?
Well, I guess I'll jump in there just to start. And, you can always go to the internet, and it can be a very scary place. So, Vic, when you started talking about what people tell you, and I had an aunt, or I heard so-and-so. And so, when you hear about these things, it can be very frightening. So I caution people to not search the internet too much. There are a couple of sites. One that we alluded to was the clinicaltrials.gov. There's also NIH.gov, which is the National Institutes of Health. And then there's something called NCCN, which is the National Comprehensive Cancer Network, which really talks about options for stages of diseases. And then, of course, the Don't Delay Today, that's scrolling underneath for our local listeners. You can get a lot of information from that website of the things that we talked about today, and also the resources that are available for you to get the necessary cancer screening, and also the support services that our colleague from DOH, Senkuta, was talking about with Project Wish. So those links are all on that website for listeners to utilize.
Dr. Rajput, you are so right, because I think that that's the number one thing people do is run to the internet. And I've been diagnosed with several things according to the internet. And so I think it is just important to speak with your doctor, an actual expert, to get the correct information and not try to self-diagnose, in that way. Do you have any final thoughts for this evening?
I was just going to add on to what Dr. Rajput was saying, and just, focusing again on this idea that breast cancer is so heterogeneous. And I think that a lot of people also say, well, my friend had this, why didn't I have it? And, again, just that the appropriate treatment for any one patient is going to be really, really specific, and it may be extremely different from somebody else. And they're both, the correct treatment for that patient. Just having a multidisciplinary care team that, provides that patient specific, information, I think is super important.
And if I could just add one thing, Vic, I just want to thank you and your team, and of course my team and the DOH, for taking the time to do this, because, this is the care that every woman deserves. And you shouldn't be scared to think that, I don't want to know because I don't want to know if I have the cancer, because God forbid if you have it, with the proper care today, we can cure that cancer, and you can go on and live your life and be there for your loved ones. So thanks for making the time and allowing us the time to share this message about education and the importance of early diagnosis.
Thank you. Thank you for having me. I know I've learned so much, and I know that this discussion has helped so many women, and women are going to share that information as well. So I just want to thank you all for this, evening of information. As you can see at the bottom, you can get all or more information, more resource information. Don't delay .today. That's don't delay .today. This has been the impact of breast cancer in the Black community with the Johns Hopkins Kimmel Center, a special live event. I want to thank you all for participating this evening, and I want you to have a great evening.
Thank you.
Thank you.